Good afternoon, colleagues. Good morning, colleagues, and good evening from different parts of the world where we are all connecting from this afternoon. And I would just want to take this moment, this opportunity to welcome all of us to this very important session for the next 2 hours or so that we'll be here dialoguing with each other. And right there on your screen, you probably could see the housekeeping rules for this 2-hour session that we're having together. Indeed, you'll get the slides from all the presentations that will be done this afternoon. And you will also get the slides from the webinars, and let us all engage. Let me encourage all of us not to shy away from asking questions, from participating actively at given moments. We are going to have Q&A sessions, which we all really should be participating in, and keep your questions, keep your notepad so that when that time comes, then you can raise whatever relevant questions for clarity or for suggestions, because we are all here as the VMMC community to try and see how we can marshal through the prevention of HIV from in our communities. Lucius, we're going to go to the next slide so that we appreciate why we are here. The objectives of this webinar really is to come and appreciate the modeling work that our colleagues that have been with us since the beginning of the VMMC programs from Avenir Health, just highlighting the impact and perhaps the cost effectiveness and projected future role in the HIV prevention. And of course, amongst ourselves, we shall have an opportunity to dialogue and with various stakeholders, various organizations, our donor partners are here, government representatives are here, and program managers and implementers. We are all here, gathered here today, and please let's not shy away from participating and appreciating why it's important for all of us to really get to use evidence for our programs. And of course, we will have an opportunity for all of us to really appreciate what could be in the horizon. How can we reprogram and relook into our programs for both biomedical and behavioral prevention interventions that we are all envisaging within our strategic plans. Yeah. Next slide. So how does the 2-hour look like for today? We are going to have a presentation or a welcome remarks by Lucius, and then of course, shortly followed by John Stover, who really has been a veteran in the VMMC community when it comes to modeling and costing, and of course, is helping us with in other areas of HIV as well when it comes to the costing. And then, of course, we are going to appreciate what other countries are doing. And we can learn from Uganda, we're going to learn from Zimbabwe, and of course, from Kenya as well. Then we'll start transition into hearing a couple of questions that will be targeted to some of our experts and our colleagues working in this area. You know, we have WRs in here, we have colleagues from PEPFAR, from UNAIDS, that will be participating in that panel discussion. And that's when you also have an opportunity to contribute in a Q&A session. Then we shall call our session to a close at hopefully 1600 hours Botswana time, or 1700 hours Botswana time on the team. So having said that, ladies and gentlemen, let us just transition to maybe passing the microphone over to my colleague, Lucius, so that we can have a few words on the secretariats and just a brief opening remarks. Thank you. Over to you, Lucius.
Thank you so much, Teboko, for the intro and opening of this session. And greetings to all colleagues. Happy to see all these familiar faces online. I'm just going to give a quick intro and highlighting this webinar, where it is coming from, and then we can go exactly into the main reason why we are here. We know the bottom line around VMMC, that it's a powerful intervention that is empowering men with a approximately 60% protective effect. One-time intervention. It's a lifelong protection that we know it's very effective in preventing HIV in heterosexual transmission. And we know it has got a significant population level impact. enhancing HIV prevention outcomes for men, regardless of the shifts in broader HIV prevention and treatment environment. We know it empowers men. As we know, VMMC is a package of interventions. This is often a missed information or key information around this intervention. It's a package of interventions offering safer sex education, age appropriate, of course, condom education and promotion, knowledge of HIV status through HIV testing, and linkage to care and treatment if found positive, and also a point of care for managing sexually transmitted infections for men. And recently, over time, other services have been offered at the VMMC site, including seeing or managing non-communicable diseases, depending on the site. Over the years up to 2023, since program inception, this is how the picture looks like. About almost 38 million men have received VMMCs by the end of 2023. This is powerful. As we have always said, it is hard to reach men with HIV services, but if we can have almost 40 million men voluntarily coming for HIV services, this is powerful. We can see from this picture how that trajectory has looked over time, with increase in VMMC per year, reaching high levels in 2017, 2018, 2019, and then when COVID happened, those levels coming down, and the levels have not peaked since then. When you look at this data in terms of coverage, you can see from the coverage map that at the subnational level, because that map on the far right is showing VMMC coverage at district level across our priority countries. There are some countries where the coverage is still far from reaching the global 90% targets that was set as part of the 2025 global targets. We know out of these almost 40 million circumcised men that VMMC is very impactful. It remains a very impactful intervention. This chart here is just showing how many new HIV infections have been averted since the program inception up through 2023. Almost 1 million new HIV infections have been averted between 2008 and 2023 by those 37 million circumcisions conducted. This translates to about 42 VMMCs conducted for every HIV new infection averted. Through 2030, again, some key important information from here is the number of new infections through 2030 averted from circumcisions already conducted. It will climb up to about 1.4 million. This represents one HIV infection averted for every 26 VMMC. So you can see the number of VMMCs needed to avert infection would decrease over time. And the benefits of circumcision already conducted so far, if we are to stop VMMC now into the future by 2050, it could cumulatively reach to about 3.2 million HIV infections averted. This is really powerful and translates to about 12 VMMCs per HIV infection. It's important, I think, to pay attention to the blue text there that is on this slide, which I won't go into now, but very powerful, basically showing that these results are very conservative results. Otherwise, the actual impact of VMMC could be more if we are really to re-look into the scenarios and the assumptions that are made into this. So where did this webinar came from? With all this impact of VMMC, it has been discussed among its different stakeholders, global stakeholders, and sub-regional stakeholders, that it's important to then incorporate VMMC data into the HIV estimates. I'm not sure, some of you might know, or most of you here, you work with the data, you might be already familiar with. Some of you are already part of those work streams or groups that you know that UNAIDS every year, it supports countries to produce HIV estimates between December and February. And that process of estimates, it goes through a very thorough review of data that is entered into the models for HIV estimates during the first week of the year as HMIS data are made available. And at that point, different partners, they come together, feed the data into Spectrum to produce these estimates. Workshops are then done to help countries, orient them, train country teams on how to use these estimates models. And there's been interest in making sure that the VMMC data can feed into these models in order to produce even more accurate estimates due to the impact of VMMC. And this exercise also feeds into other key partner processes, for example, pay for COP processes, global fund application processes, seeing where this is important. So there was a work stream that was then established to say, let's ensure that VMMC data is accurate. We generate subnational coverage estimates that can feed into this estimates process. And it was during that work stream that then it was discussed to say, let's have a discussion or a broader discussion around the impact of VMMC, and let's have this discussion with all the stakeholders in the country and global and regional. Basically, the work stream is working to support countries and make sure that VMMC data is of high quality. It is harmonized across different platforms. As we know, there's been issues in terms of VMMC data when you look at different sources, and also to make sure that countries are supported in generating these district-level HIV estimates that can feed into this modeling or estimates process that countries produce every year with support from the HIV estimates and modeling group that is led by UNAIDS. So basically, that's where this is coming from. I'm highlighting where the program is since its inception, its impact, showing that it's a very powerful intervention with the number of new HIV infections averted so far, and how that can translate to in the years to come, even if the program was to stop, and then where it is fitting in within other processes happening within countries as far as estimates process are concerned, and the work being done through this work stream. That's all I had in the meantime for now, to just give a basic orientation and the basic understanding of where the webinar is coming from and where this discussion is coming from. Thanks, and back to you, Tebo. Over.
Yeah, thank you, Lucius, for the highlights. The number of infections averted because of the good work the men and women in this webinar have been doing over the years. And indeed, in terms of speaking to those numbers and how we got to those numbers, let me just invite along John Stover, one of our veterans in this program who've been working with us in the costings and the modeling, to really take it off as a keynote speaker for this afternoon session. John, you ready? I think you can take it away.
Thank you, Tebo. All right, we'll get started here. Oh, okay. All right, so as most of you know, when VMMC programs got started back in 2008 or so, there were a number of studies conducted that showed that they would be highly cost effective and even cost saving in many countries. And even some more recent modeling analyses done by the HIV Modeling Consortium a few years ago showed that VMMC continued to be cost effective in most settings in the short term. However, the epidemic today is much different than it was in 2008. So the question arises, is VMMC still a cost-effective intervention given the situation we're in today? So let's look at how things have changed since 2008. This chart is showing you the incidence among the adults 15 to 49 back in 2010 in the blue bars, and then in 2023 in the orange bars. So in each of these countries, you can see a large decline in incidence, average of about 2/3, 67% decline from 2010 to 2023. And this is, across all countries. So we have a much different situation with incidence being much lower, which means that obviously VMMC will appear more expensive to avert one new infection. The other big change that we should highlight here is on the treatment cascade. So back in 2010, most ART programs were just getting started and coverage was quite low. But today, across the spectrum of countries that are priorities for VMMC, most countries are either at or very close to the 95 target. So here the blue bar is showing you proportion of people who know their status. The orange bar is the proportion of those people who are on treatment, and the gray bar is the proportion of those on treatment who are virally suppressed. The red dashed line shows the 95 global targets. And as you can see, most countries are pretty close to that. What that means is that they have the conditions in place for continued decline in incidence in the future. So as we look past 2024, we can expect in these countries for incidence to remain low and even become lower. Let's just show us some information about the historical scale-up in circumcision. So we're going to do some modeling for each of these priority countries, and I just wanted to show you the sort of the basis for that. What we're seeing here is circumcision coverage. So this is the percentage of males 15 to 49 who have been circumcised. For each country, the dots show you an estimate from a survey, from a recent DHS or a FIA. And then we projected that past the last survey to 2023 on the basis of the reported number of new circumcisions since the last survey. So we have quite a range from countries that are very far from the 90% target, and some that have actually achieved it and exceeded it already. So the main question we wanted to look at here was, will VMMC remain cost effective in the future? And if so, for how long? So we know that the cost effectiveness depends on incidence. If incidence continues to decline, at some point, VMMC would no longer be cost effective. High levels of treatment coverage and viral suppression will support continued incidence decline. So our main question is it still cost effective to scale up VMMC programs to reach the global targets? And if so, how long should they be sustained? So the first chart here is showing you the cost per infection averted. This is a discounted cost per infection averted of achieving the targets. So in this case, we assume that each country scales up from wherever it is today in terms of circumcision coverage to the global target by 2030. So any bar that's below the line, like you can see there for Eswatini and Lesotho and Mozambique and Uganda and Zimbabwe, that means that these programs would be cost saving. That means that the costs averted by not having to treat people who didn't become infected are larger than the costs to scale up the VMMC program. And if the bar is above the line, it means that there is a net cost. But in most cases, you can see that these are fairly competitive costs in terms of cost per infection averted. So VMMC, at least for the next few years, certainly remains one of the most cost-effective programs we have. So then the next question is, what happens after 2030? Should we continue to support VMMC programs once we've already achieved the coverage targets? To do this analysis, we considered a series of scenarios. One where VMMC programs stop all operations in 2030 once the targets are reached. And then what if instead they continued for 5 years or for 10 years or 15 or 20 or 25? So basically, we're looking at the question for donors and domestic governments. Should we continue to fund VMMC programs for 5, 10, 15, 20 years after 2030? To do this analysis, we've assumed that once circumcisions VMMC programs stop, then the circumcision rates would gradually return to their pre-2008 levels. So if no new VMCs were provided, 15-year-olds would not receive VMMC, and they would just be carrying along whatever traditional circumcision coverage they had. And over the next 40 years or so, overall coverage would return back to 2008 levels. We've assumed that all other interventions remain at constant coverage, discounted at 3%. And we actually ran the analysis all the way to 2090 in order to capture the full benefit of circumcising people even in the year 2050 and 2060. So this gives you an example of the results, and we're looking at Mozambique here on the left. And this is showing us the cost, the incremental cost per infection averted, discounted at 3%, by stopping, by scaling up to 2030 and then stopping, shown here, or continuing for another 5 years, shown here, which means that continuing for 5 years past 2030 in Mozambique is still cost savings, or continuing the program for 10 years or 15 years. And here, 10 years is still cost savings, 15 years has a net cost, but it's still quite low. But you can see how the costs increase as we go further into the future. And the main reason for that is the incidence curve, as we project that incidence has declined substantially in Mozambique already, and will continue to decline as we go forward into the future. I see we have a question from Dr. Felix. Do you want to go ahead?
you can go ahead, John. I think we'll take questions a little later if you doesn't
Okay,
mind.
all right, thanks. We've done this analysis for a whole variety of countries that you can see here. So what you're seeing is that the first bar is the cost per dolly averted, in this case, not infections, but cost per dolly averted. If we continue the program for 5 years or 10 or 15 or 20 or 25 years. You can see that the costs rise in all countries because of reducing incidence. The pink bar, horizontal bar, is an idea of the cost per dolly threshold that countries would be willing to pay. So this is generated by looking at what countries are actually spending their money on in their health programs. This is domestic expenditures for health programs. And this paper that's referenced at the bottom by Derudi et al. Calculated what countries were actually spending per dolly averted. So we can compare VMMC programs with that. If we look at the first set of bars for Eswatini, we can see that the cost for VMMC programs is well below that threshold for continuing 5, 10, and even 15 years into the future. But after 20 years, then it goes above that line. And across the other countries, you can see the various situations. Generally, what this tells us is that VMMC programs will continue to be very cost effective for the next 5, 10, and 15 years in most settings. Beyond that, then we have to reassess. Then the funding for VMMC programs might be more effective going into other health programs. But for the next 15 years, VMMC remains a very cost-effective option. Now, the analysis we've been showing you has been all at national level, but we recognize that incidence varies significantly by subnational region in many countries, by districts and even by province, as you can see from the map here. So we've also done some subnational analysis, and I'm just going to show you one example from Zimbabwe, where here we applied the model at a provincial level to look at the cost per infection averted of reaching the 2030 targets. And you can see variation across the different provinces. And 4 of the provinces, 5 of the provinces, actually, it will continue to be cost savings during that period. And in the other 4, it will have a net cost, but all quite low. So this type of analysis can also be helpful because it's not a strong cutoff that just your country all of a sudden doesn't become cost effective. That will actually vary by subnational region. So there will be some, let's say, districts in your country where perhaps the costs are already high because coverage is high and incidence is low, and others where it will continue to be a good investment well beyond the period where it doesn't look so national. So in summary, although we recognize that the epidemic is very different today than it was in 2008, our analysis suggests that VMMC programs remain very cost effective in most settings and will remain so for the next 5, 10, and even 15 years. There are, of course, important differences across countries and through subnational regions. So decisions about cost effectiveness of VMMC should really be based on subnational analysis where that's appropriate. Cost effectiveness will decline, however, as incidence drops. So certainly need to be reassessed after 15 years or so. And programs and donors need to be responsive to these changing conditions in order to hopefully accelerate the short-term response and bring a subnational focus to their analysis. Thank you very much.
Thank you, John, for that elaborate presentation. Very detailed indeed and very, very insightful. And it's very, very exciting looking at the numbers and what we're able to achieve so far and what it means actually for the future prospects of continuing with the program and for a couple more years so that we can avert a couple more infections. And it's a clear message to all of us in the programs, how efficient and effective and bootstrap and how quickly we need to be running so that we can reach our intended targets as we're doing our programming. And you spoke about examples from Zimbabwe and Mozambique and others. And on that note, I think let's get to hear perspectives from the countries as well. Kaba from Zimbabwe, you're here. The focal point of VMMC from Zimbabwe. I know He's one of the veterans as well, who's been with the program for many, many years. Yep. So, Baba, welcome, my brother, and take it away. But before you do, let me just remind our colleagues, we have close to 120 participants in here. Very exciting. And please feel free to go on the chat, have your questions in there, and John and others and Wole and Lucius will all attempt to be responding, given the amount of time that we have to respond to those questions as they come through. And please, it's for all of us to interact for the next couple minutes or the next hour and a half or so. On that note, Klaba, take it away, my brother.
Thank you very much, man. Good morning and good afternoon, colleagues. I'm going to share a few perspectives from Zimbabwe. And thanks, John, for sharing how things look like from a modeling perspective. So I'm going to share a few slides from Zimbabwe. My slides are not moving. Can you see my slide?
Yeah, we can see your slides.
Okay, let me just reshare again.
Yeah, perhaps. Yeah, we can see the slides now. You can try and move. Yeah.
All right, thank you very much. So I'm going to share some slides from Zimbabwe. Wow. I'm failing to move my slide.
Can I share them for you, Sino? Is that okay?
Yes, please go ahead. Please
Okay.
go ahead.
Okay, you can let me know when to move.
Okay.
Yeah. Yeah.
Okay, thank you very much, Lucius. Please move on to the next slide. Okay, so this slide just shows in a snapshot the HIV epidemic situation in Zimbabwe, where we see that overall we have a population of about 1.3 million who are living with HIV. And with the new infections of about 25,000 per year, this is of last year, but the figures are a little bit lower now. And we see that young women are more affected than the young men. But we see also that there is some variation in the geographic distribution of HIV prevalence and also incidence. So the southern part of the country, we see that there is a high, and in some pockets of the country, we also have some higher incidence as compared to other parts of the country. Next slide, please. Okay. When we look at what has happened over time, we see that the HIV incidence in Zimbabwe has continued to decline. Like was alluded to earlier on in John's presentation, that HIV has been on the decline, incidence has been on the decline. And we see that from the Zimbabwean context, we at epidemic control, or I know it's not a static number. When you look at our new infections and our new deaths, the numbers have significantly gone down. And it attests to the other earlier slide on the 95, 95, 95, where Zimbabwe has actually exceeded in all the three 95s. Next slide. Next slide. Okay. Now, how then do we situate VMMC within the overall landscape of HIV prevention? Now, there are a number of interventions that Zimbabwe is currently implementing, and that just shows in a snapshot the different interventions that are there. the PrEP interventions, HIV testing, the VMMC program, the prevention of mother-to-child transmission, the oral PrEP, and the post-exposure prophylaxis, and also ARTES treatment and the STI program. So now when we look at these slides, we do see that, or these interventions, that the complementarity of the different interventions actually increases our overall impact. And also situating VMMC within this, now it means we then need to look at what is the overall contribution of each intervention to the overall number of new infections that are being averted. So Zimbabwe is implementing a full-scale HIV prevention intervention across, and with VMMC being one of those interventions. Next slide. Okay. When we look at the different HIV interventions, we see and we look at HIV incidents across the country. I did allude to earlier on that we do see that the southern part of the country, we have higher incidents on this part of the country here. So meaning when we look at our interventions within the broader HIV prevention perspective, it means we therefore need to look at a differentiated approach to service delivery, where we are looking at where does the VMMC going to give us the biggest mileage, where does maybe PrEP or PEP, depending on the intervention, gives us the most significant impact, and specifically which populations will serve to benefit the most from a particular intervention. Next slide. So when we now look at the VMMC program, we therefore started earlier on, the earlier years of the VMMC program, we adopted the accelerated implementation of the VMMC, where we're looking at really a business and approach, where we wanted to reach the highest numbers possible. And as we're moving towards the end of that phase in 2018, we then introduced a follow-on strategy, which we called the Sustainability Transition Implementation Plan, which was really meant to ensure that in view of the changes that we are seeing in the infections averted, we are quite aware that the impact of VMMC will still continue to be effective, but maybe it needs to be embedded and positioned for the long-term sustainability. And so we now implemented the transition, and we can move on to the next slide. So now, having done that, we then moved all the VMMC strategy from being a standalone strategy, but to be part of a combined HIV and STI strategy, which takes into account that we have different interventions that we are implementing in Zimbabwe. And we moved from looking at VMMC as a standalone intervention, but which is then built into the broader combination prevention. And as you can see here, there's a vision there of an AIDS-free Zimbabwe, and the goal is to accelerate the response towards ending AIDS by 2030. And we also have sub-goals there that are speaking specifically to reducing the number of new infections. And so as we speak now, we have moved the VMMC into the broader HIV prevention, which also fits within the broader HIV strategy for Zimbabwe. Next slide. Now, what then becomes more important as we've been looking through our data is to have a clearer understanding and appreciation of where we still see the new infections. And I'm speaking specifically looking at, when we're looking at VMMC, we're looking at PrEP, we're looking at condom use. Are we able to deliver precise interventions for the different population groups? who's getting infected. We have always said maybe sex workers, but what exactly about the sex workers? Or in our border areas, what exactly is it about the border areas? So through the use of our data, we are just starting an initiative where we're saying we would really want to look at differentiated HIV prevention programming, where we ensure that each service is provided to the right locations with the right intervention at the right time and to the right people, so that we use our modeling data that we have in relation to where we are having highest HIV incidence, and with the appropriate interventions that are actually helping to bring that down. And so we are seeing a number of interventions that are coming together. And this is an initiative that's since infancy, and it will be scaled up in the course of the year as we move with the VMMC in the long term. Next slide. I've already mentioned this, that we see that when we look at our incidents, we have about 11 districts that are contributing the highest numbers of new cases of HIV. So it means even when we look at VMMC, it then will be a differentiated approach where we are saying, is VMMC going to be impactful in these areas or not? And so for us now, and taking also into account what John just said, we then have to be deliberate about those districts where we're seeing highest numbers of infections. And so it will not be a generalized scale up of VMMC, but quite a targeted one in response to what the data is saying. But most importantly, also remembering that we're implementing this within the broader scope of HIV prevention. Next slide. So, okay, yeah, thanks. So in conclusion, would like just to mention that VMMC still remains a critical component to the HIV prevention package, and it is an avenue through which we have been able to reach the highest numbers of males when you compare to any other program in Zimbabwe. Maybe what might have been underutilized is that opportunity that we have seen over 2 million men that could actually have been accessed with the other services. And this has been happening, but maybe suboptimally. And we also see that the VMMC program, its benefits transcend beyond HIV prevention, and it also includes HPV. So I think while we are focusing on the declining incidence, we also need to be watchful and look at what happens to HPV, what happens to other STIs. And we know that to an extent, VMMC can actually contribute to those, and within the broader sexual and reproductive health context. It is relatively cost effective. This has already been mentioned, and over time, it's a one-time event that goes into someone's full reproductive health life. So VMMC will then need to be continued to be implemented, but within the context of appreciating what new evidence is coming. And as Zimbabwe, we are already to a great extent positioning ourselves for that. And some of the things that we've already implemented is reviewing the curriculum so that all providers, we've done that for nurses, with something that we plan that medical doctors, as they complete their training, currently they don't have a requirement where VMMC procedures become part of their logged procedures, but it's something that's under consideration, looking at all the online training for VMMC, which is also currently on its phased implementation. So yeah, we are quite aware that our data, as it speaks, it's been useful in the past to shape how we have scaled up. And now as we look into the long term, we are starting to integrate VMMC and ensure that it's situated such that it is available long term, but within a routinized system of service delivery. Thank you very much. This brings my presentation to and thanks, and over to Jen.
You're on mute, Maddox.
Oh, thank you, Sino, for that perspective from Zimbabwe. Indeed, a lot of learnings from how you are transitioning your service delivery approach towards integration, but still maintaining the essence and the importance of circumcision within the public health program. So having said that, let me also welcome our colleague from John Stover, John Davis, if you are here, so that you can also give us some perspectives from the modeling work that you have done in Kenya.
Sure
John?
thing. And I'll keep it pretty brief because I know we're a little bit behind schedule. Let me share my screen. Okay, hi everyone. My name is John Davis. I'm a research analyst and modeler with Avenir Health. We were asked a few months ago, earlier this year, by the Kenya VMMC team to perform some analysis to guide the future strategic direction of the VMMC program. So I'm going to give kind of a brief overview of the modeling and the results from that analysis. We looked at 4 different scenarios. One was stopping the VMMC program altogether after 2023. The next was achieving 90% coverage targets for the 15 to 29 age group. The next scenario was maintaining the current total annual volume of VMMC, but allocating most of that volume to the 15 to 29 age group. So this is kind of a status quo scenario, but with more of an age targeting for the 15 to 29 group. And then the final scenario was cutting the current volume by half, but again, allocating most of that to the 15 to 29 group. And for all of these, we looked at VMMCs performed over the next 5 years through 2028, but we measured the impact through 2050 to capture all the infections averted by VMMCs in the more distant future. For the modeling, we used a mix of DMPPT2 as a tool to kind of convert between coverage and VMMC volume, and we used goals ASN to estimate the infections averted per VMMC. We also did a comparison to PrEP, and the goal was not to put them in competition side by side, but since we're talking about cost effectiveness in a setting that could, determine budget allocation and funding decisions, I think it is necessary to benchmark against some other prevention method. So we looked at both oral PrEP and long-acting injectable PrEP for a few different priority populations with kind of middle of the road assumptions about adherence and coverage and efficacy. And likewise for PrEP, we modeled administration for 5 years, then discontinuation and measuring impact through 2050. And these are the cost inputs we use for the model. VMMCs are around $41, oral PrEP around $82 per person year, and long-acting PrEP $234 per person year. And this includes the commodity cost and the healthcare delivery cost. And the bottom line here is that VMMC on a unit cost basis is relatively inexpensive, but it also provides protection for life. And on a very high level, we found that VMMC is relatively cost effective when we compare it to PrEP, about 3 times more so than oral PrEP and 6 times more so than CAB PrEP. But again, keep in mind, this is measuring impacts over a long cost horizon where after 2028, VMMC continues to avert infections while PrEP does not. And I didn't mention before, but all of our analysis was restricted to Nyanza province, where the VMMC program is focused. And the Kisumu and Homa Bay counties were shown to be the most cost-effective counties for VMMC. The county level results did vary quite a bit. In a couple of the counties, maintaining current volumes would actually meet the 90% targets, while in other counties, current volumes would either stagnate or result in declining coverage because it's not keeping up with population growth. And in some of the counties, there's also quite a bit of benefit to be realized by achieving 90% coverage targets. In Migori County, for example, that could avert up to 3 times more infections. These charts, the dashed black line is the 90% coverage target, and the colored lines are showing coverage over time for each scenario. And I think the most interesting thing to look at here is the yellow lines for the status quo 2023 volume scenario. We can see that in some counties like Homa Bay, coverage actually declines over time just with maintaining the status quo. Whereas for other counties like Kisumu and Turkana, the yellow line will actually exceed the 90% coverage target over time. And this is showing between the counties the relative cost effectiveness. In Turkana, VMMC is the most cost effective, and these variations are due to differences in incidence between county. Turkana having the sorry, I said this wrong. This is more VMMC is required to avert an infection. So Turkana would be the least cost effective here because it has the lowest incidence. And if we look at infections averted between the counties, I wanted to draw attention just to Homa Bay and Migori. These are the counties where there's the most benefit to be realized by transitioning from scenario 2 status quo to scenario 1, where we're achieving the 90% targets. And this last summary slide is looking at dollars per infection averted for oral PrEP and also for VMMC. The dashed bar here is looking at Nyanza province as a whole. These green bars are looking at VMMC for each county. And I think it can be a bit surprising seeing the difference in cost effectiveness between, you know, CAB-LA especially and VMMC. But the way to think about this is that you have a much lower unit cost for VMMC, but we're also measuring over a long time horizon. So VMMC is really collecting more and more infections averted over time, while PrEP doesn't have that ability. And what was I going to say? That's actually the last slide. So if there are any questions, feel free to drop them in the chat. I know this was also kind of a very fast walkthrough of the results. So if anyone is interested in learning more about it or talking more, we can definitely do a deep dive offline. I'll drop the Avenir VMMC email in the chat, which you can contact with questions about this or anything else VMMC related that Avenir can help with.
Great. No, thank you, John. I think your message was quite succinct and clear and to the point, that amongst all other prevention programs, and particularly PrEP, as we're also scaling up PrEP as part of that package of prevention services, looking at the long-term protection and the costs of the inputs into that particular program, you made your case, quite convincing case, I must admit. But like you said, a bit more in-depth analysis may need to be undertaken to appreciate that even the more. Having said that, colleagues, maybe we may want to transition into another section as we thank our country colleagues, those country experiences from Kenya, from Zimbabwe, and usher in our colleague and friend, Angelo, to also take up this next section of the panel discussions and the Q&A that would follow thereafter. As I take a small break. Thank you so much, Angelo, and over to you, my friend.
Great. Thank you so much for bringing us this far, and thank you all to our presenters for bringing us really, really great insights. Good morning from New York, and good afternoon to all of you, wherever you are. So we have a very, very powerful panel, and I know we have a lot of questions and comments in the chat. We will get to as many of those as possible. But to start us off, so we have a powerful panel of colleagues from different places and spaces. From WHO, we have Wole Ameyan, Licious Zembe from UNAIDS, Maya Sunundram from the Bill and Melinda Gates Foundation, our PEPFAR colleagues, Sarah Nawukela, Todd Lucas, and Valerian Chigundu. And you've already heard from some of our modelers. You heard from John Stover and John Davis. We also will have John Eaton from Harvard, Catherine Kripke from Avenue Health, and we will also have from the government of Kenya, Ambrose Juma, as part of this panel. So we have, again, very, very powerful panel. We have a lot to cover and to hopefully decipher from the presentations that have been given already. I think to start us off, I'm going to actually start with you from the modelers. Actually, I'm going to start with Catherine Kripke to get us started. Right into the modeling numbers. To you, Catherine, or any one of our modelers that we have, what are some of the key assumptions behind these modeling results that John Stover just presented and John Davis as well? And how do those account for any variability across different country contexts?
I think I would have to ask John Stover to come in to comment on the analyses that he presented, and John Davis as well.
Great. Thanks, Catherine. John?
John and John.
Yeah, I'm sorry. So could you repeat the question that you want us to focus on?
Yes. The question is, what are some of the key assumptions behind the modeling results, and how do they account for any variability across different country contexts?
So the main factor is incidence, right? So what we're using is an estimate of what incidence is that's coming from the national HIV estimates that each country produces. Based on fitting to prevalence data, we don't usually measure incidence directly, but the current incidence and the future trend are the main factor affecting the differences across countries. A secondary factor would be the costs. We know that the costs for circumcision are vary by country, generally somewhat higher in the Southern African countries and lower in the East African countries, but that would be the second major factor, I think.
Great. Thanks, John. And keeping still with the modeling team, and any one of you could answer this as well. What additional data or refinements could further enhance the accuracy and utility of VMMC models for stakeholders? Any one of you could answer that.
I feel like the data that we have is pretty good. So I don't know that we need to focus that much on improving the modeling. I think we need to really focus on getting the VMMCs done.
Great. Thanks for that. And actually, speaking of getting things done, I'm gonna move on to Maya now. In terms of funding priorities, how does the Bill and Melinda Gates Foundation plan to prioritize funding for VMMC in light of these modeling findings, especially in regions where there are some documented challenges for rollout?
Thanks, Angelo. Can you hear me?
Yes,
my network is quite poor. Okay, so sorry, I won't turn on my camera just to save the network. But I think it's a really important question. The foundation has been engaged in the VMMC program really since its inception and even during the trials, and recognizes its strong contribution to the overall HIV response and driving down incidence. And as noted by the modeling efforts, the continued incidence reduction that it and protection that it provides over time into the future. We've shared some of our priorities in this space. I think it's important, and I should note, we're more of a catalytic funder, a smaller funder in this space, and we have never been a large scale. Well, I shouldn't say in recent times we have not been a large scale service delivery funder. We have historically transitioned that to our PEPFAR colleagues who have really taken the leadership role in support, as well as the Global Fund. So we see our role more in supporting country level decision making, particularly around the context of sustainability of the response and informing country level decision makers with modeling evidence like this. I think there was a question in the chat about plans for John to extend these analyses. We do have support through Avenir, who have agreed to provide this support to countries upon request. So that support is available. We also continue to support the regional and global work through UNAIDS and WHO, and have some country specific work ongoing in our priority countries. I hope that answers the question, and I hope you could hear me.
Yes, we could hear you, and that did answer the question. I have a quick follow-up. Again, Catherine has said we have the modeling now, and it can help us to target better, in terms of where we need to be focusing. What role do you see technologies and or other innovative approaches play in increasing efficiency and effectiveness of VMMC delivery? And that's for you as well, Maya.
Sure. I mean, so I think with technology introduction, we need to all be really thoughtful about what that will do for us in the context of, increasing demand or improving efficiency or effectiveness. I mean, VMMC as a surgical, the traditional surgical approach has been very effective and has reached 38 million boys and men to date, without dramatic technological innovations. Those come at a cost to introduce. And so I think that countries need to make those decisions for themselves and really think through carefully the potential impact for technology relative to the cost of introduction and the cost of scale up, and considerations for how they want to sustain the response and the role of VMMC in that going forward. So I think there's a number of factors to consider, is I guess what I would say. And I think that's part of this country level decision making that we would hope to inform.
Great. Thanks so much, Maya. And now moving to again, I'm gonna go back to the modelers, and particularly actually maybe Jeff Eaton, you can comment on that. Looking at the future projections and some of the conclusions that our colleagues have shared, what do you see as any potential fears for the VMMC program? Looking at the numbers that have just been, is there anything we should be concerned about as a program generally that you can speak to?
Yeah, thanks. So I think one thing to emphasize is, John highlighted really clearly that everything about the future impact of VMMC, what the magnitude of that might be, really hinges on what HIV incidence will look like in the future. And the projections that John presented for many countries suggested a pretty optimistic vision of what that could look like in the future. But that's not something that just happens. That makes some pretty strong assumptions about what the HIV program, both in terms of the treatment program and the prevention program, will look like in the future, and continuing to sustain current levels of interventions at a pretty high level, maintaining high testing and treatment coverage, maintaining relatively high levels of condom usage, levels of PrEP usage that are incorporated in those projections. And I think the unique thing about VMMC amongst that constellation is it's something that we can do now that essentially buys us preventive impacts in the future. And so I think that's one thing is that underpinning those incidence projections that John identified as so critical is very strong assumptions about what else we are sustaining and the levels at which we're sustaining them. And that's, I think, another way to think about the value and the power of VMMC is we're not going to see massive impacts tomorrow from VMMC because we're tending to circumcise relatively young men who only are exposed to higher risk of HIV acquisition 5 or 10 years in the future. But the flip side of that is everyone we're able to reach with circumcision now is some amount less PrEP, some amount less condom usage, some amount less HIV testing that we would need to do in 5 years, 10 years, 15 years in order to sustain the trajectories that we want to be on.
Great. Thanks for that response, Jeff. I'm going to now move to PEPFAR, to our PEPFAR colleagues, and Sarah or anyone, Todd or Valerian, please feel free to come in here. Really speaking to some of the operational challenges. We operating in a space where there is either flat funding or reduced funding, and the picture doesn't look very good. From where I'm standing, right now, looking into the future. From PEPFAR's experience, what are some of the key operational challenges in scaling up VMMC programs, and how does this new modeling potentially help to get them some of these addressed? Again, in thinking about the current and projected future funding environment. What are some key operational challenges in scaling up VMMC programs, and how does this new modeling help to get some of these addressed? That's to you, Sarah, or your other colleagues from PEPFAR.
Yeah, you're on mute, Sarah.
Sorry about that. One would think that I know how to find the mute button after so many. Here we go. So thank you so much, Angelo, and for the great presentations that were really very thoughtful, and also the questions that have been coming in the chat. Clearly, we've made great strides from where we started, 2008, to where we are now. 37 million men is no small feat to achieve, especially for a program that has almost largely been vertical and very donor dependent, but we've managed to make great strides in terms of scaling it up. Having said that, it hasn't been with challenges, and one of them, as has been alluded to, has been funding. As Maya has said, PEPFAR has been one of the biggest funders for the VMMC program, but in so doing, it has been limited in the scope of how much can we scale it up. It is limited by what it is able to target in specific geographical areas, really driven by what the data is telling us, where we're able to make maximum impact. And in so doing, we haven't, reached the depth and breadth of where we would have loved to go. And really this underpins the fact that we really need to think about how can we diversify this funding, issue moving forward, especially as you've alluded, Angelo, that, funding is flatlining, and that's the reality of life. And we've got to think around that. And I was happy to listen to the presentation from Zimbabwe, how they have been forward thinking. How can we transition this? How can we make it part of the, our whole system of, health access, etc., and, bringing that in. And I think those are some of the questions which, many of the VMMC countries need to ask. How can we diversify this funding? And what I see is some of this data that is showing us, and I think looking at it being at, at the subnational, area, where it pinpoints to you, where should I go? I have limited resources. This is what I have available. Where can I get that maximum impact? And using this data, and I think what John and the team have done, expanding it to other countries as well, so that they can better understand those SNUs. Where am I seeing the highest incidence? Maybe those are where I need to focus, where I need to go to. But also we can't underpin the fact that, we have a youth bulge in many of the countries that we are targeting. And maybe that can also inform, that population that you need, that would really need the services. Thinking of how you can, better target it. So I like the concept of differentiated prevention, figuring it out, which goes with everything we are differentiating, how we are delivering services. So really bringing that also into the prevention arena, I think will be quite helpful. But I think one of the things that have been very challenging has been that fact that it has been almost a standalone program, and we need to think that, that approach of doing business. It may not necessarily be the best way moving forward. And those are the things that we need to think about. And being a standalone, program, we've put our resources in there, and some of the things have been pretty expensive. The demand creation efforts we are doing to get those 30 million men plus haven't been cheap. They've been expensive, and sometimes they may not be readily, moving with the decreased funding. We may not be able to do them at the scale we have done them, and we need to rethink how we can be able to do business moving forward. And of course, the integration is good. We want moving from a vertical to, an integrated, but it is also going to have its challenges, especially if, we are considering that it is a surgical procedure. You have to have those capabilities and those resources as you move it lower down. And we need to rethink how some of these countries going to be able to ensure that those surgicals, necessary for surgical, procedures to be done safely and of high quality are in place. So those are some of the thoughts and, challenges which we've seen and maybe need to be thought through as we move into the next phase of how VMMC is going to be delivered. And I will let my colleagues, Todd or Valerian, add on if they do have any other ideas or thoughts. Thanks.
Thanks so much for that, Sarah. And actually, maybe I'll ask a specific question to Todd or Valerian about something you alluded to, sustainability. Is something we've been hearing a lot about. National governments have to take more responsibility to fund their programs. What are some of PEPFAR's insights into how that is, the planning around that, and are there any insights or best case scenarios that you are already seeing about governments that are rising up to take more responsibility, and what do we need to do more of to ensure that this actually happens? Because again, it has to happen.
Angelo, can you hear me?
Yes, we can.
Yeah, thanks very much, Angelo, and thanks for the presenters. Thanks, Sarah, for the previous responses. So briefly, in terms of sustainability, first and foremost, from the perspective of PEPFAR, is to understand that it's now more important to consider supporting governments directly, as well as trying to localize the program. So we think that it will be very important to strengthen collaboration with the national governments and enhance public and private partnerships, including considering having VMMC as part of a package that can be supported through private providers, having that specific code under insurance, so that in case their clients would like to receive services from private providers and they are covered by insurance, they can actually be supported. And then we previously supported the VMMC program using both the direct service delivery and the technical assistance. So I think it will be important now going forward to think about what some of those areas we supported previously through technical assistance, instead of going forward to support direct service delivery, such that direct service delivery can actually be left to national governments. And then PEPFAR can also continue supporting and prioritizing key interventions, for example, safety and quality, where PEPFAR has very strong clinicians who can actually come and support the field in those areas. And then lastly, trying to understand that sustainability is going to look very different from what we've been doing right now. The actual scope of the program, services, and the annual volume of the VMMC may actually change going forward. So we are not likely to continue doing business the same way once the program is going to be sustained. We are likely to see a couple of changes, and we need to actually try to embrace those changes.
Great. Thank you so much for that, Valerian. Much appreciated. Now, moving on to another segment of our panel. Wally, I'm going to come to you at WHO. WHO plays a really critical role in VMMC strategy development and guidance. In light of the modeling results that just got presented, what steps is WHO taking to support countries in utilizing evidence-based approaches to refine their VMMC strategies and policies?
So thank you, Angelo. And I think for me, I'll just, first of all, maybe put a bit of a positive spin to the conversation. And when I listen to programs, I've just listened to Sino. I see country program officers on the line. And then you look at the numbers that have been achieved since 2007, 2008, when the first recommendations were made. I think it's what an achievement, really, that we can really look back on and say, countries, with huge support from PEPFAR and from partners, have been able to achieve, these milestones. I think that's probably where I would like to start. Sustainability and integration and what have you. For me, one of the critical things that I've observed in that conversation is how we look at sustainability as more like an end game to achieve, rather than a lot of process-driven issues that we need to sort of put together and see how we allow those processes to work, and then we can have sustainable programs. Maybe two things from John's presentation that I think, from WHO's perspective, we need to now begin to to look at to support countries. I think first is the fact that, and I think Sarah mentioned this, the fact that we need to now go into the subnationals. For me, now at this stage of the program, it doesn't make sense, really anymore to begin to look at national VMMC programs. It's more now, subnationals, the sub-districts, the lower cadres. How can we make sure that we understand where the gaps are, and how can we support the countries? Like you mentioned, how can we support countries to really focus on those sub-national units and the districts where the gaps are? I think from WHO's perspective, we have to now be able to sort of zero in to where those gaps are in terms of service delivery. I think that's one. Now, the second thing is our work on now supporting countries to move from what some speakers have called standalone services. From the inception of VMMC, and from the randomized control trials that informed the recommendations, there was never any intention for VMMC to be standalone or to be provided as just one service. I'm not sure we will go through how that became, but we now have guidance, on how countries can move from that so-called standalone programs into integrating, into mainstreaming is perhaps a better term, But that will take a lot of effort. It will take a lot of strategic thinking and planning. We have a tool that can help that. But it will also take, certainly some more, additional commitment from our funders, who I know, despite what incredible support that they've given over the years, perhaps this is the time as well to now see how we can provide, additional resources to get through that last mile. And for us at WHO, we continue to support these efforts.
Great. So Wale, can you? And I really like the sound of integration, especially. Can you think about let's say my country, Uganda? What are some practical ways that WHO envisions that integration could happen in Uganda, for example? What are some practical steps that you see with the framework that you've described? Like, what are some practical ways you can see integration?
Yes. So again, this is going to be country specific, context specific, certainly. But if you look at Uganda, but also other countries, I think one way of looking at integration is at what health system level. So, for instance, the primary healthcare level, is that. Again, I'm very careful saying this because you in some countries that makes sense, in others not so much. But in certain service delivery points, whether at PHU level or maybe in other cadres of the health system, I think that question is how you can look at providing integrated coordination and services from the perspective of which health facility level you want to provide the services. So I think that's one. Now the second is, in terms of the services, itself, the package of services and which population you want to provide it to. For WHO, you would have seen that we have been making a very strong push towards men's health. And that is critical. So VMMC is for men, but we know that the services and the issues and interventions that men need and the gaps that we see for men transcends prevention. It's testing, it's treatment, it's viral suppression. So one way to also look at integration is, looking at the man, a person-centered approach. You look at the man and you see how you can provide integrated services from that male perspective, rather than from just an intervention perspective. So I'll say those two, but I'm sure there are others in a way that again makes sense to the country. It's at the end of the day, it is countries, and I like that Maya actually pointed this out. It is countries are going to be the ones. They know their context. They know what the health systems demand. So we have to be in a position, certainly, where we put and even putting countries in the center is a bit of a wrong way of putting it. We have to allow countries to assume the leadership role that they have, really. And they should be able to then decide and counsel on what they want to do, and then we will just be there to support and to provide guidance, using our comparative strengths. Again, not forgetting that we have a lot of experience already. I'm seeing Sarah on the screen. PEPFAR have, it's been such a rich repertoire of information and knowledge that I think we can look back on from partners to the next phase.
Very fascinating. Thank you so much for that, Wale. Moving on to your neighbor at UNAIDS, Licious. Really, the results that we've just received, we just gotten, really critical to evidence based data driven decision making. And UNAIDS plays a really critical role in the decision-making around these interventions. How can UNAIDS support countries in using VMMC coverage and modeling data to set realistic targets?
Thank you. Thank you so much, Angelo. And yes, my neighbor, I'm just one floor down from Wale. Good. This is a very good question, and it speaks to where also this webinar is coming from around the use of data, its generation, and how that is very helpful to inform the broader process of estimates, which then informs progress on the HIV response broadly. So for VMMC, UNAIDS is working with stakeholders and also supporting countries through this data work stream, which is organizing this webinar together with the WHO. So basically, working with the countries to strengthen their reporting of VMMC data, meaning accurate reporting, the more granular, the better in terms of its disaggregation, and making sure that the data is also reported even at the sub-national level. So UNAIDS is playing that role to work with countries through our SI advisors to strengthen that part, working also closely with Avenir Health, who are working with the countries to help in generating these sub-national estimates coverage, working with other partners. So that's the I think the critical role which UNAIDS is playing, and encouraging countries to come forth and supporting that exercise in terms of making sure that the reporting, either be to the Global AIDS Monitoring Platform, GAM, which is popularly known as GAM, is strengthened and is complete. Participating and the completion of the data reporting in the templates through this exercise of subnational coverage is also done to the greatest extent as possible. That then informs how accurate coverage estimates can be estimated at the subnational level. So that's the role, I think, in short, I can say UNAIDS is playing. And over time also revising the indicators that are being reported to UNAIDS. So every time, now and then, especially now, next year, there will be a review of the indicator registry. So UNAIDS also playing that role in terms of working with the countries to strengthen what indicators are being reported to GAM, strengthening country reporting of VMMC data. The more granular, the better, as I highlighted earlier on, and working with Avenir and partners in terms of how that is feeding into the tools such as DMPPT2 and this modeling work to generate accurate estimates. This then feeds into the overall spectrum related HIV estimates broadly, which then informs our overall HIV response progress in terms of the different indicators that come out of that. Thanks.
Great. And what kind of support can countries expect from UNAIDS to help improve that reporting? Because it is critical. Like, what can countries expect from UNAIDS going forward to support the reporting?
It is basically, I think, bringing the relevant people together. We know for VMMC, for example, program data for VMMC, it stays with program people. So linking the strategic information people with the program people, especially for programs like VMMC, it also applies to other programs like PrEP, for example, where the data is sitting with program people, and then there's need to link with SI people, because SI people are the ones that are then engaged a lot in terms of feeding this data into the global AIDS monitoring platform. So UNAIDS improving over and over again on engaging the relevant people on the table and ensuring that data is collected in time and it's reported into the relevant platforms for it to feed into the subsequent processes that happen afterwards. That's the support, specific support that UNAIDS can play to know who they need to invite when the reporting process starts to ensure that all the data is reported. Yeah.
Great. And before I go back to some of our other panelists, I think I would not have done myself a service as someone from civil society if I didn't ask you this. VMMC, often feels like the forgotten child. There's a new, baby in all of the other interventions. And I'm also one of the proponents for not pitching one intervention, over another. We need combination prevention. We need choice. We need people to be able to have multiple interventions to choose from, but often VMMC feels forgotten. So what role will UNAIDS continue to play to ensure that global advocacy is sustained, so that more investments are given to VMMC to ensure that, especially in high burden countries where, as you saw from the modeling, this is a game changer. VMMC continues to be a game changer. So what role can UNAIDS do to ensure that the investments continue, and that even the advocacy itself is funded and sustained?
Thank you, Angela. I know this question was going to come, and it's a very good question and a powerful one. So regarding advocates for VMMC, and this I'll respond also asking everyone online, because it works as a teamwork. UNAIDS has got that powerful voice. When we put out something out there, many people read it. For example, every year we have a global AIDS report that is released around July. That covers different aspects, progress on the HIV response overall. And in that report, there's a big section on HIV prevention. It's an opportunity to highlight where the program is at and what's happening in the program, highlighting some case studies around VMMC. It's a powerful advocacy piece for the HIV response overall, a report that is read globally. So it will continue, and will continue to have a piece that highlights VMMC in that report, knowing that it's a report that is read broadly, globally by almost everyone interested in the HIV response worldwide. I'm always the guy who's always checking the draft of that report to see if there's any VMMC mentioned somewhere, and working closely with Wale to say, what can we include? How can we message the VMMC section in that report? So that's one powerful piece, I think, that we can strengthen. And it would be even stronger if people reach out and say, hey, this is what we did in Zimbabwe. This is what we did in Kenya. This is what we did in Ethiopia. Can this be highlighted in the global AIDS report that is read by almost many people globally? That's one piece of global advocates around the program. Then the other piece also is through press releases or web stories. We've done a few, for example, when Lovelin and team released the cost effectiveness study some time back. I think we even did this together with you, Angelo. We can do these web stories or releases of anything that is insightful that is coming out of the work on VMMC. Also, this requires everyone here to come forth and say, hey, UNAIDS, can you use your advocate's voice to amplify this work that we are doing on VMMC? So we are there to amplify that work and open to put it out there where many people can have access to it and many people can read it. So that's what I can say for now. There could be many other opportunities, and welcome for any other ideas that we can use the UNAIDS voice to amplify VMMC work and put it out there as a key intervention for men. Over. Great.
Thanks for those insights, Lucius. And our last panelist, Ambrose Juma from Kenya. How has Kenya used data from VMMC modeling and programmatic results to inform policy development in Kenya? How is this data used to inform policy development or policy review? If you are speaking, you're on mute, Ambrose.
Yeah. Good morning, good afternoon. I hope I will be clear.
Yes.
Because I've moved out of the office, and it may be a bit noisy. So in terms of what the government is doing, is that the government appreciates that the advent of VMMC has greatly helped to reduce the HIV prevalence in the areas where it's most affected. Because just like Zimbabwe, HIV has a geographic bias. We have regions which are more affected. And like now, about 12 counties or 12 subnational units where VMMC is being practiced. When you look at the numbers living with HIV, it accounts for about 45% of the national HIV burden. And yet the subunits are just about 25%. So what the government has done, one, is that we have included the male circumcision in the insurance package. So we are hoping it will go through so that going forward as part of sustainability, people will be receiving circumcision, the insurance will be taking care of it. These are national insurance, which is now compulsory for all Kenyans. Two, there's the issue of the user fee. And this one is common in the subnational units where some people prefer going to private. So people are encouraged to take whatever option they want. They can go to private and get the service and pay, or for now, go where it's being offered for VMMC for those communities that don't circumcise. And then for the rest, we'll be using the insurance. So the government is taking up that. And the government has gone further to enforce that even for those communities that circumcise culturally, the issue of safety has become a challenge. We have started seeing a lot of adverse events in communities that circumcise culturally, and now we are trying to address the issue of safety in the culturally circumcising communities. That is what the country is doing. And the last one is that the government policy is circumcising for all, not only 15 and above. It's circumcising all, including the 10 to 14, and it allocates some money to take care of them. Although it's still at a lower level, but that's what the government is doing. Over.
Great. Thank you so much for that, Ambrose. And Catherine, before I come to you, I have one last question for Ambrose, and that is, what lessons can other countries learn from the Kenyan approach to VMMC program planning and execution?
The lesson that other countries can learn is that community participation should be on the front line. And the community should feel that there's something they are doing for their health. They should not leave it to all for the external support. That is one thing that we are really, the message we are passing around. That because we tell the communities that your health is your responsibility, and therefore what we are doing is for your safety, you should contribute something towards it. You should not just wait that all the cost is made by whoever is supporting it. That is what I can tell. And the second thing is engaging the national government treasury by justifying how many circumcisions have been done, how many HIV infections have been averted, and therefore the need for the government to start allocating some funds from the central government. And that one is what we are working on.
Thank you so much for those insights, Ambrose. We're now actually officially into our Q&A session. There are a number of questions that came into the chat, and we'll be directing them to any number of you, our panelists. But first, Catherine, please go ahead.
Yeah, thanks. I'll try not to take too long. So I wanted to go back to this idea of the subnational targeting. And I want to caution us against interpreting the modeling data too literally. And of course, the country program managers really need to, leverage their knowledge of the country situation. And the reason why I'm raising this is because in some places there can be a lot of migration and within the country, from rural areas to urban areas and so forth. And you might see that the HIV incidence is higher in the urban areas, for example, but the people might be in the rural areas when they're at the ages when they're more likely to be willing to be circumcised. So just take into account when you're planning your subnational targeting, what the dynamics in your country are. I think, in general, I'm in favor of subnational targeting by incidence, but for VMMC, because it is a lifetime intervention, like you have it once and you're protected for life, regardless of where you go. So where we have countries that have settings with very mobile populations, that has to also be considered with the subnational targeting. You know, for PrEP, like you're protected when you take it, and so subnational targeting makes a lot of sense. But for VMMC, we need to be thinking about it a little bit more broadly than that.
Right. Thanks so much for that, Catherine. A number of questions did come in, and I really thank the panelists for answering them. We have one that I think hasn't been answered. How do countries maintain quality as we shift responsibility to lower cadre of healthcare workers? Anyone?
So
Yeah.
I can, yeah, okay, Sarah, go ahead, please. You go.
Oh, okay. You chime in later.
Yes.
But I think for me, things to do with safety and quality are paramount to VMMC. You know, just from the name itself, it's a voluntary, intervention, and by that virtue, we are telling the clients who are coming to us, we're going to do something for you, but we're going to do it safely and of high quality, and we need to adhere to that. So it is really paramount and it is important. And that's one of the reasons why here at PEPFAR, we do have a system to really monitor, are there adverse events happening? How is the quality of the services that are being delivered? And we're very, very intentional to make sure that the programs do adhere to some of the set standards to ensure quality and safety. And as we shift, and we know we did shift actually, because many of our service providers are mostly lower cadre nurses who this wasn't part of their initial requirements or job description, but have been trained and have done a great job to help us reach to that is 37 million. But we do have to ensure that they have the training, they have the skills, they have the mentoring and monitoring, and refresher trainings to ensure that they're up to date with the those quality standards, safety standards. But also I think thinking, if we go a little bit back, because we have had to do all those trainings in in service, if we put it back to pre-service training and begin training them early, and then but we do continuously be able to to monitor them as they're delivering services, I think that's going to be very helpful. But even now, as we make those shifts away from direct service delivery, but helping the countries to build those systems of ensuring quality and safety, I think is going to be important. How can we help build those resources for them to make sure that as they are taking up the mantle of being the leaders of these efforts, that they do have those systems set in place to monitor. But I do also I think want to re-echo one comment that was made from a colleague from Kenya around community engagement. I think also bringing in the community, I think, is also going to be key, because they need to understand some of these aspects. Why do we need all this information we are training them or bringing to the communities? I think if you have those community champions as well, I think it is also going to go a long way into helping us to ensure the safety and quality measures. Wale, over to you.
I'm actually not going to say anything very different from what you said, but no, absolutely, safety is of utmost is very paramount. You will recall as well that a few years ago we had to make a shift in the age group, for VMMC. I've seen a question on that in the chat. Moving it from what it used to be, 10 to 15, and it's all about just making sure that what is essentially a prevention procedure continues to be very, very safe. People say VMMC is very safe. It's just a very few severe adverse events, probably less than 1%. But for a procedure like VMMC, you have to be in a place where it's actually going to zero. We don't want anyone to come to a service and not receive a service that is completely safe. So having said that, I think for safety, it's sometimes we relate safety with the cadre of the worker, and sometimes it's not really it's not always true. So for instance, if you go into other services, we've actually found that lower cadre might actually be able to provide certain services at the same safety rate as other cadres. I think what is important is that countries just make sure that their standard operating procedures, their notifications, and the trainings that Sarah mentioned are regularly updated, and we just make sure that we routinely monitor how these services are being provided in a way that is safe for the clients.
Great. Thanks, Wally, and thanks so much, Sarah, for that. We did receive really great questions, and again, all of them have been answered. If your question hasn't been answered in the chat, please feel free to raise up your hand. We can unmute you if you want to ask the question directly. One thing that I wanted to actually to raise up is about the cost. And maybe let me ask that. What constitutes the VMMC cost of $41 in one of our modelers? If you could please speak to that, that would be great.
I think that was John.
Yes.
I think it was John Davis, I think.
Hi, I can actually answer that because I was the one who pulled together the costs for that analysis. Oops, sorry. So I also put the answer in the chat as well. So there was a paper that came out a couple of years ago that looked at the cost of VMMC across a number of countries. And so we used that to come up with an average cost for VMMC, and then we adjust it by country based on salary scales. So so that's where that cost came from. It was a very systematic study that looked at the entire cost of service delivery for VMMC. So unfortunately, there haven't been too many recent studies of cost of VMMC. I saw there was also a question in the chat about the cost in Zambia, and I don't think we have any recent primary data from Zambia. So we would just have to, come up with an estimate with a similar approach.
Great. Thanks for that, Catherine. We have about 2 minutes left. And if any one of the panelists would like to touch on an issue or a question that you saw in the chat or something you wanted to say as we wrap up this segment of the agenda, please get off mute and say it. Any one of us as we wrap up the Q&A and panel part of the agenda.
Yeah, so I can just kick off just very briefly to say that VMMC has done really well. I think moving forward, we have to go into an era of prioritization. So prioritization in terms of where the services are being provided. So we need to look at areas where due to different factors, they've received less services over the years. But then secondly, we also have to see how we integrate and provide services in a holistic way that goes beyond VMMC, but moving broader into men's services.
Fantastic. Any final thoughts from anybody else? Sarah, John, and John?
Yeah, I think Wally has covered it very nicely. I think maybe my last addition would be around that community engagement. I think they're going to be very big advocates for us. And certainly, I know you mentioned around the question around how can we amplify, tell our story, be the advocates for our program. And I think as we're moving into World AIDS Day, we should use many of our platforms available at the different country levels to advocate and tell our story and our successes, and and that the fight is not over yet, or the struggle is not over yet. Whatever, I shouldn't be using that language, but pardon me. But I think we need to be the advocates for our program moving forward, and also leveraging those in the communities, those who have received these services, though, and are okay, doing well, and are happy. just being there to advocate for us and tell the story, I think will also be very helpful. And we kind of emphasize the need of our country teams to help us, in amplifying and telling that story at the country level. Over.
Great. Thanks so much for that, Sarah. And my really what I really picked up, I picked many things, but the two that stuck out for me is that countries know what their needs are, and they also know what their health systems are capable of and what they are. And all of us in the global community are available to support the countries to do what they need to do to bring this to scale and to use the data that we have and the modeling that we've gotten to scale up and sustain their programs. And the second really critical message is we must center the communities and what the community needs are. I want to thank all of the panelists for your really great insights. I want to thank all of you for the questions and for your active participation. This is not the end of this conversation. It is a continuing conversation, and I thank you for the opportunity to be part of it. And with that, I would now like to hand over to my colleague, Ian Wanyeki. Over to you, Ian.
Great, thanks. Give me a second to share my screen. All right, is it visible? Perfect. I'll be walking you through the HIV estimates process and some of the tools and timelines used, just so that participants it's a refresh from an earlier webinar, just so that it's clear how the VMMC estimates fit in this process. I think Lysias mentioned this early on, that estimates are really a cornerstone of the HIV response. And these are well enshrined in the UN political declaration. So I won't spend too much time on that. They enable us to review, monitor progress over time in terms of trends, and see whether we're improving or not. And so you see incidents going down. That's probably an effect, as mentioned, of various prevention interventions, including VMMC, as presenters previously mentioned. Just in terms of the estimation process, HIV estimates teams work, UNAIDS supports HIV estimates teams on an annual basis to update their estimates. These teams are compiled by experts in country, normally somebody from the MOH, from the NAC, sometimes people from civil society, and they use the best available data related to HIV, so ART, ANC, PMTCT data, and they use that the various surveillance data, and they use that to generate HIV estimates, which are then reviewed by the teams. UNAIDS and partners support them and review the estimates. And at the end of this process, not at the end, part of that process also includes tagging on VMMC indicators to that. And so we're about to go through a series of workshops to help countries update their estimates, both the HIV estimates and the VMMC coverage estimates for those countries that do VMMC programming. In terms of timelines, as I mentioned, we have the workshops coming up. Then PEPFAR countries, there's a timeline of the end of January. And so this timeline of January 30th also applies to all the VMMC countries, to ensure that they have their input data updated. And that data then is used when the countries generate their subnational estimates and feeds into various processes such as the COP planning process as part of the US government. And then again, countries also use that information for their own internal planning. There are multiple tools. I won't go through each and every tool. But sometimes you hear, as you're talking to stakeholders, you do hear about different tools, Spectrum, Naomi, DMPPT. Now, for VMMC related people, the one you'll hear most about is really the DMPPT tool. And occasionally you'll hear about Spectrum and Naomi, which are used to generate the HIV estimates. I think in the next slide, I tried to do a workflow. No, sorry. This covers really the DMPPT tool. Maybe I'll let my colleague Catherine just walk us through some of the key functions of this, because it has quite a lot of functionality, and she's probably the most well-informed about the different functionality it has. Over to you, Catherine.
Thanks. Yeah, I think the purpose wasn't really to go through the DMPPT2 in detail, but just to mention that the tool is freely available at the at the URL that's on the slide. And there are a number of different analyses that it has. It can help with target setting. It can help with analyzing coverage by age and district, and other analyses. So please use it. And if you have any questions, you can email us at that email address on the slide. Back over to you, Ian.
Perfect. So one other tool that's also used, which is an output from the DMPPT2, they generate some output data, and then this feeds into a viewer, an online viewer, whereby countries are able to view some key VMMC coverage estimates. And so this is going to be updated. It hasn't been updated yet, but it will be updated shortly. Just a quick last slide, just to mention the process. This part on the left, countries, once they've updated their input data, so the countries are in the process of updating their VMC input data. We haven't reached the end of the year, so they're still going to be adding that information and also doing quality checks. So when they've finished updating their VMC data, they'll upload it into the DMPP tool, and then they will send an output of that file back into what we call the AIDS data repository, just so that there's integration of that information with the rest of the HIV estimates. Countries then run their subnational HIV estimates, and one of the steps there is using that file, and they're then able to generate the various indicators that are used in some of the processes, such as the COP data pack. I think with that, I'll stop there. I think that was my last slide. So just to encourage countries to reach out to their UNAIDS SI focal points, because they're SI focal points in country who are aware of this process. And so in case there's changes and sometimes the template changes slightly, don't hesitate. They'll reach out to the UNAIDS focal point. The focal point helps to coordinate. And I think this was one of the questions early on from one of the presenters. How do we help? UNAIDS helps with the coordination and ensuring all the key partners are on the table and talking to each other and using various pieces of information. So I'll stop there and hand it over to WHO for the closing remarks. Thank you.
Yes. So Maddox, are you still there? I think Maddox informed that he was having internet connection challenges, but yeah, thanks Ian for that presentation. I think it's always useful to to have this view about the tools that we use. I'm sure the slides will be shared, and colleagues will be able to have these for their records and for their perusal. So if it is fine, Lysias, I think we should close now. From me, I'm going to just say thank you so much to to colleagues. Certainly Lysias, who's organized this webinar, and UNAIDS. I would like to thank for sure all of the presenters. So the speakers, I thought they've been fantastic. The presentations were on point. They were on time as well. And certainly to all the attendees who have made this webinar very engaging, with very great questions and discussions. My thanks, of course, goes to Angelo, who moderated the panel discussion ever so well. And thanks to my WHO colleague from Botswana, Maddox, we call him Maddox, who chaired this webinar in a most engaging way. So we're going to come back, again. I'm sure, Lysias, maybe there'll be a part 2 of this. Let me give it to you. You round us off and we close.
They've been very engaging questions. Thanks so much, Wale. We will organize a part 2, and if colleagues feel there's a specific area of this program that you want to be covered in another engagement like this, please bring forth those topics. We're happy to organize another discussion like this, and then we can go through it. I think that's all from me, Wale, and thanking everyone, and also appreciating the Gates Foundation who are supporting us to be able to do this work with you, or appreciating you, Maya, for the support. Thanks so much, Wale and Madix for moderating this and helping this to work out as the way it is worked out. Yeah, over. Thanks.
Okay, fantastic. Thank you so much, guys, and see you again soon. Bye.
Thank you and bye-bye.